Hello and welcome again. This time we'll be talking about some general NICU principles, a guide to having a conversation with the neonatologists, and then having them not stare at you blankly and then go do something else after you finish rounding. No conflicts of interest. Again, just like the other presentations, this information was collected in the summer of 2024, and there may be other different correct ways of doing things. A little checklist: if you're in your pediatric surgery critical care fellowship, get to know the neonatology team. And here's what we're going to be talking about from head to toe problems of that you're going to see in the NICU, especially problems of prematurity and terminology that you'll be using for those conversations. Let's start with some general terminology. Gestational age is the time from the last menstrual period to either the current prenatal visit or to the birth. Postmenstrual age, gestational age plus the age since birth. Preterm infants are those born less than 37 weeks, with some subclassifications of extremely preterm being those born with less than 28 weeks of gestation, and near term being born between 34 and 36 and 6/7 weeks, with full term infants having 37 or more weeks of gestation. The corrected age is the age after the due date. A small for gestational infant will be more than 2 standard deviations below the mean, or less than the 10th percentile for gestational age. Intrauterine growth restriction, IUGR, different from SGA. This means that the fetus is falling through growth percentiles in utero. Causes of SGA or IUGR include maternal age, race, high altitude, nutrition, medications, illness, placental insufficiency, vascular disease, hemoglobinopathies, respiratory disease. As you can see, a whole range of factors. Like SGA, LGA, large for gestational age, more than 2 standard deviations above the mean, or 90th percentile for gestational age, which can be due to genetics. The most common reason is maternal diabetes, as well as some congenital disorders such as Beckwith-Wiedemann. Very low birth weight infant is born weighing less than 1,500 grams. An extremely low birth infant weighs less than 1 kilo. Numerous consequences of prematurity: intraventricular hemorrhage, post-hemorrhagic hydrocephalus, and periventricular leukomalacia being the neurological complications, retinopathy of prematurity, hearing loss, respiratory distress syndrome and surfactant deficiency, chronic lung disease, bronchopulmonary dysplasia, patent ductus arteriosus, adrenal insufficiency, low GFR, feeding tolerance in necrotizing enterocolitis, temperature stability, anemia, and numerous others. Going from head to toe, the infants, just talking about common problems that you'll see. Analgesia and sedation is one reason that can generate a number of emails from our NICU partners to the surgical team if members of the surgery team are not paying attention to this when they're trying to do infant care. Infants obviously do feel pain and they should be treated. Options include acetaminophen unless you're trying to keep the duct open, opiates, alpha agonists. Generally, NSAIDs like ibuprofen are avoided in those less than 6 months of age due to immature kidney function. Opiates do have some effect on neurological development and can cause withdrawal or neonatal abstinence syndrome if there is a maternal exposure or neonatal exposure more than 1 week, and can require a longer taper to avoid those withdrawal symptoms. Caffeine is used to treat apnea of prematurity and has been shown to improve neurological outcomes. It's given as a loading dose and then a maintenance dose to premature infants until reaching 35 to 40 weeks, corrected, and then that reduces the rates of apnea prematurity, postoperative apnea, bronchopulmonary dysplasia, and again, improved neurological outcomes. Sedation is generally managed with some combination of fentanyl, benzodiazepines, and alpha agonists like dexmedetomidine and Presidex. What should you be doing or recommending for your surgical patients? There are multiple different correct ways. This is my personal current preference, which is acetaminophen alone for laparoscopic surgery with tiny incisions, or if they've not undergone a surgery, with PRN morphine or fentanyl for non-ventilated babies if needed. And then if they are on a ventilator, a combination of Presidex, dexmedetomidine, and either fentanyl or morphine. You can extubate onto dexmedetomidine. I usually don't extubate until the morphine is less than 0.02 or the fentanyl less than 1, although there are some individual institutional variances if the infant's on for a long time, has built up some tolerance, but trying just with that to avoid having apnea and then needing to be reintubated. Neurological complications that you'll see in the NICU, hypoxic ischemic encephalopathy, or HIE, occurring between 1 in 10 in 1,000 births, resulting from some decreased cerebral perfusion around the time of birth. There's usually the acute injury and then some partial recovery with a secondary deterioration. And the critical thing is to avoid any hypoglycemia or hypoxia that could worsen the outcome. Intraventricular hemorrhage, not an ischemic, but a hemorrhagic event, a complication of prematurity, typically originating in the place called the germinal matrix, which is a collection of neuronal precursor cells in the developing brain with a very fragile vasculature. Risk is markedly increased to less than 32 weeks. And in those with some disturbance in cerebral blood flow or coagulation disorder. Screening ultrasound is recommended in all preterm neonates less than 30 weeks at 2 different time points. Grading of the IVH is into 1, 2, 3, and 4 categories. Management is with correction of any coagulopathy and then potentially shunting for post-hemorrhagic hydrocephalus if it develops. Neurodevelopmental outcomes, there is mixed data, with some saying that for grade 1 and 2 IVH, there is little to no degrees of impairment, but others suggesting that there is some long-term impairment for those categories. There is less controversy for grade 3 or 4, which has high rates of mortality, high rates of cerebral palsy, and neurodevelopmental impairment. The extent of the hemorrhage may matter more than the grade. For example, a localized grade 4 would be better, certainly, than a bilateral grade 4. More on this topic can be read in this McCrea paper, which is a good review. So moving on to the cardiovascular system and how to select a vasoactive for those who are in refractory shock after fluid resuscitation. The NICU is maybe one of the few places left you'll see dopamine used. There is data that epinephrine and dopamine have similar efficacy and safety in undifferentiated neonatal hypotension in low birth weight infants, as well as in septic shock, although in that category norepinephrine may be a better choice. Again, for pulmonary hypertension, dopamine and epinephrine provide inotropic support. Norepinephrine and vasopressin are less well studied in neonates, and as a result, use less frequency, although it's not that they're not efficacious compared to dopamine. There is also data that in septic shock, the use of hydrocortisone can improve outcomes, and so you're going to see more of steroid use in the NICU and also other populations. As the infant is transitioning from fetal circulation, if you get an echo super early, you might find PDA, pulmonary hypertension, PFO. Those are all potentially normal if you get the echocardiogram early. In a healthy full-term infant, the PDA will functionally close in around a day, although it can later reopen. We'll be talking about the ductal-dependent congenital cardiac diseases and the consequences of closure in those infants, or the consequences of persistent PDA in the cardiac week. All right, moving on to the lungs. So we're going to save talking about advanced modes of ventilation that you'll see particularly in the NICU, including NAVA, NIV, RAM cannulas, things like that in the neonatal respiratory failure week. But just some general principles here. We generally don't allow PO feeds while on non-invasive ventilator support until they're at or below 2 liters or so of high-flow nasal cannula. Tachypnea can sometimes be the only herald of sepsis or a serious problem developing. You'll see teams talking about apnea, bradycardia, desaturation spells, or ABD events. These are generally in preterm or near-term infants, can be caused by infection, reflux, aspiration, congenital heart disease, hypoxia, chromosomal abnormalities. It's important to know when you're rounding how that was broken, if it was spontaneously, if it required increased oxygen or bag valve masking or simple stim. Swallow skills do not develop in the infant until 34 to 36 weeks postmenstrual age. And so if you are treating an infant, maybe recovering from surgery, and you're wondering how to feed, and they're only 32 weeks, then you're going to have to use tube feeds. It is important to not ignore the development of oral skills to prevent oral aversion, and as soon as it's safe to do that, to initiate it. Bolus versus continuous feeds. We'll discuss this further in the nutrition week, but generally only do continuous feeds for post-pyloric feeding or infants with short-gut syndrome and some very low or extremely low birth weight infants. Otherwise, we prefer to do it in a bolus fashion. And then reflux therapy. So this is an excerpt from Pediatrics, which is the journal of the AAP. Conservative measures to control reflux, such as positioning, manipulation of the feeding regimen, have not been shown to reduce clinically assessed signs of reflux in a preterm infant, and there's a lack of efficacy for pharmacologic agents as well as evidence of harm with gastric acid blockades. So try to avoid the routine use of PPIs or H2 blockers, as they may not help and they may cause harm. Replacing GI losses is something that you'll have to do. Generally, replace losses greater than 30 cc's per kilo per day, either 1-to-1 or half to 1 with some type of fluid depending on what you're losing. If it's gastric fluid from high G tube or NG-OG output, you could use half or normal saline. From a small bowel ostomy, you could use LR normal saline, or from ascites, could use FFP or 5% albumin. Specifically for gastroschisis, something to think about is the increased fluid requirement in the first days, which is also discussed in the nutrition week, as well as a 10% rate of necrotizing enterocolitis, which can be severe. Some of the worst cases of necrotizing enterocolitis I've ever seen were in full-term gastroschisis infants. Just the rapidity of the progression to necrotalis was remarkable. They also have 10% incidence of atresia. You may see discussed these terms used interchangeably, but there is a difference. Rapolo versus Salem sump. You can see on the X-ray on the screen right that all the holes are in the last little bit of the tube, the radiopaque tube there. And this Rapolo was typically used to decompress an esophageal pouch, but in small infants, this allows all the side holes to be in the stomach for decompression, whereas a traditional pump might have its sump tip in the side hole in the esophagus if it were to be used. All right, you get a consult from the ED or NICU, a common one, newborn with dilated bowel and X-ray on distended abdomen or bilious emesis. So bilious emesis should be presumed to be from a bowel obstruction of surgical pathology until proven otherwise, and requires timely clinical assessment, including a history if they are sick, presence of a hernia. If you see an infant with bilious emesis and you send them down for upper GI, and they say, oh, there's gas in the scrotum, suggesting of inguinal hernia, and you missed that on your exam, you end up looking kind of silly. Look at available labs for presence of acidosis, any findings such as thrombocytopenia on a CBC. And then typically the first thing that you look at is an X-ray, which can often suggest if there's a proximal or distal obstruction, and in tandem with the history, guide further workup, with the caveat that an X-ray of a midgut volvulus can look however it wants to, including normal. Proximal intestinal obstruction. Etiologies include congenital duodenal obstructions, including duodenal atresia and webs, as well as an annular pancreas. The emesis or OG tube output may be bilious or not, depending on the location of the obstruction to the ampulla of Vater. Other etiologies: proximal jejunal atresias, malrotation with midgut volvulus. On the screen top right, you'll see a congenital duodenal obstruction. Usually, the patient history, prenatal findings, and X-ray are sufficient to diagnose without additional imaging. However, if there's uncertainty, an upper GI can be performed. Treatment of a congenital duodenal obstruction or a proximal jejunal obstruction is not an emergent surgery, and Usually you want to obtain a TTE first to rule out any comorbid cardiac conditions associated with the condition, although in some institutions, if you have a normal fetal echo and a baby that's pink, not requiring oxygen, that may be sufficient. If there's any concern for midgut volvulus, such as interval of healthy feeding or the presence of distal gas, concerning abdominal labs, should prompt additional evaluation. Whether or not that'll be initially an ultrasound or an upper GI will depend on your institution. A lot of places are moving towards an initial screening ultrasound first, especially because that can sometimes be done before the radiologist even comes in at night to the hospital or on a weekend, for example. Distal intestinal obstruction, jejunal ileoatresias, colonic atresias. This is where you'll start to see a lot of different associations, which I've put an asterisk down at the bottom. For jejunal ileoatresia and meconium ileus associated with cystic fibrosis, and for colonic atresia meconium plug, neck may have associations with Hirschsprung's. Other etiologies of the obstruction include Hirschsprung's or an ARM, inguinal hernias, small left colon syndrome, typically seen in maternal diabetes, which is self-resolving, meconium cyst, duplication cysts, septic ileus, and again, malrotation midgut volvulus. These kind of x-rays on the right with these massive dilated loops tend to suggest some form of atresia. Again, if there's concern for midgut volvulus, you should undergo the usual workup which we've just talked about. Otherwise, unless you find the cause of obstruction on your physical exam, like an ARM or a hernia, the first step will typically be a contrast enema, which can suggest the etiology of the disease. If there's a microcolon, an inverted recto-sigmoid ratio, suggesting in the first case some form of atresia, or in the second case Hirschsprung's. If contrast does reach those dilated loops, it can suggest incomplete obstruction, either a type 1 atresia like a web or a meconium ileus or plugs. What size infant can you send for contrast enema? It has been done down to 800 grams, but they do tend to have temperature stability issues, and so try not to do that unless it's going to trigger an operation, which you may not want to do on that size infant if it's a non-urgent surgery. Can you irrigate before a contrast enema? Again, somewhat controversial. Some radiologists will want you to wait a period of 12 to 24 hours prior to the contrast enema, holding irrigations, with a thought that decompressing the distal, the colon, can mask the recto-sigmoid ratio, although some folks don't have a problem with that. What infant is safe for a suction rectal biopsy if you're trying to rule out Hirschsprung's? Generally down to 1.6 kilos or so. And then transitioning to full thickness rectal biopsy. There's no exact date. I was trained to do it after 6 months of age, although some folks are still performing sectional rectal biopsies up to a year or even beyond, keeping in mind that your yield and the ability to tolerate it will be decreased. So common neonatology things to say that the infants have dumb kidneys. They have a remarkably reduced ability to either concentrate or dilute or acidify, alkalize the urine, and this makes them more susceptible to electrolyte disturbances, including acidosis or alkalosis. If you don't have the right chloride acetate ratio in your TPN, for example, you can cause some hydrogenesis yourself. Pretty easy. Hematologic. You'll sometimes get consulted for a newborn passing blood per rectum. This will be discussed more in the GI bleeding week, but consider on your diagnosis differential swallowed maternal blood. Other hematologic conditions, hemolytic disease of the newborn, and neonatal alloimmune thrombocytopenia. These are maternal antibodies versus fetal red blood cells and platelets, respectively. Depending on how severe it is, it may need transfusions or IVIG, and if there's development of worsening bilirubin levels, can need therapy for that as well to prevent neurological complications of kernicterus. Vitamin K deficiency. Vitamin K does not cross the placenta well, and for whatever reason, parents like to refuse it. Newborns that don't get this shot are about 80 times more likely to develop severe bleeding, and 1 in 5 of babies that develop bleeding from vitamin K deficiency die, so it's pretty serious. The risk extends to about 6 months of age. Transfusion goals in the NICU last consensus. There is some early evidence that restrictive transfusion practices had higher rates of neurological complications, but that didn't pan out when it was looked at in later studies. And so depending on the oxygen requirement, the sickness, where you are in the world, and the PMA of the infant, your transfusion goal may be somewhere between 7 and 12. And platelets, somewhere in the 25 to 50 range. There is a study that infants transfused platelets at 50 had higher risk of dying than were transfused with a lower platelet threshold. Another thing which may be gone, depending on when you're watching this presentation, is the transfusion-associated necrotizing enterocolitis and whether or not it's real, and whether or not feed should be paused. It seems like there's a trend towards possibly not doing that anymore, but we'll see. The chart from JAMA with red blood cell transfusion thresholds in the NICU, and you'll see, depending on how sick the kid is, critical versus non-critical, and how far away they are from birth. And they found no difference in death or disability in infants that were followed up to 24 months in those who had received either a liberal or a restrictive transfusion threshold. All right, moving on to some infectious disease principles. So you'll see something called a sepsis rule-out. An infant who may have some ABDs or other events that or a temperature instability concern for infection. If there's low clinical suspicion, general practice might be to check some labs first, and then if those show any additional concern that they're developing sepsis or infection, proceeding with the remainder of the workup, which is blood cultures and an empiric antibiotic course of usually 36 to 48 hours of broad-spectrum antibiotics, typically AMP and GENT. For maternal GBS positive or maternal chorioamnionitis, there's not consensus on whether to give antibiotics or to observe. It's going to be dependent on institutional and neonatology practice. Some endocrine issues, so hypoglycemia. Transitional hypoglycemia in the first 48 hours of life can be normal. However, persistent hypoglycemia can have neurological complications, and you should look out for it in babies with omphalocele, as it can be associated with Beck-Wiedemann syndrome, which can also have hypoglycemia. Congenital adrenal hyperplasia is a group of autosomal recessive disorders that have alterations in hormone production. And if you're consulted for ambiguous genitalia or adrenal sinus, you need to consider the potential for life-threatening salt-wasting forms of disease and obtain stat endocrine consultation. Some additional recommended reading from the Manual of Neonatal Surgical Intensive Care that I gave you. A couple chapters just for general NICU principles. Moving on to a quiz. There's a premature infant who's ready to feed. She has full intestinal length and there's breast milk available. And how was the best option to start feeding? Ad-lib PO, POQ 3 hours, by a tube every 3 hours, or continuous. And unless you're remarkably advanced for your age, you probably may not be able to swallow just yet and will need tube feeds via an OG tube. You're consulted for hematemesis in a 5-hour full-term newborn who was born via spontaneous vaginal delivery. What kind of test can you do to determine if this is swallowed maternal blood? Hemoccult test, a Naps-Downey test, direct antiglobulin test, or maternal autoantibodies to the immune platelet antigen? The answer here will be the Naps-Downey test. This other one is for neonatal alloimmune thrombocytopenia. Last question here. You're consulted for a 2-day-old infant with bilious emesis who never passed stool. The abdomen is a bit distended but soft and non-tender. You don't find any hernias and you have normal labs and vitals. X-ray shows dilated loops of intestine and no rectal gas. Diagnostic test of choice should be obtained next. It seems like you don't have too much concern for a midgut volvulus. Unless you find something else when you're looking, the next answer should be a contrast enema. which is likely to show a microcolon, and depending on where an atresia is, will be the length of the colon and whether or not it gets into the small bowel. Likely this is going to be a jejunal ileal atresia. All right, that concludes this week's. See you next time.